I think there's a really interesting question about what's useful to know about the patient before their brain injury, what's essential. And I think it depends a little bit on what we're looking at. In terms of assessment of things like behaviour and is there possible mood, for example, we obviously would want to know whether there's any history and was it extensive. But I always ask for a little bit of caution in my team about that, because I equally do not want there to be an assumption that if a patient has, for example, a history of depression, that they must be depressed now. You know, we have to be more careful than that, because otherwise we run the risk of potentially, you know, trying lots and lots and lots of antidepressants or other medications that might not be needed. So I think we want to know whether there's relevant history, but we also have that as part of our formulation. We don't leap to an assumption that it means that there's something of that nature now. I mean, in that more general sense, obviously, there's quite a lot we might want to know about the patient for when we're thinking about any best interest decision making, which is, you know, perhaps slightly different from the assessment, although sometimes one might be, you know, sort of incorporating more than one thing at once. I mean, we'd certainly want to know things like who were they closest to, you know, in their family and friends, who would we expect there to be reactions to, if anything. I mean, those are the obvious things that sort of spring to mind.